Hello, everyone. My name is Thomas Modine. I'm a consultant cardiac surgeon, and it's my pleasure today with Professor Lars Sondergaard to record this video in which we are going to discuss the current and very dynamic landscape of transcatheter mitral valve treatments and briefly discuss early experience in mitral clinical trials with Intrepid system. We will be also debating on transcatheter mitral valve replacement versus repair solutions. In my presentation, we're going to discuss who are not optimal candidates for optimal mitral valve transcatheter repair. These are my conflicts of interest. We will be covering which patients are not appropriate candidates for transcatheter mitral valve repair systems based on clinical factors and anatomical factors. I extracted this sentence from Joseph Bavaria, who's a TVT STS registry chairman, in which he says, science tells us what we can do, guidelines what we should do, and the registry is doing and reflects the reality. The gold standard today for mitral interventions is mitral valve repair, and we should repair whenever it's possible. And if it's not possible, we should replace. We should also be able to replace if we have a bad quality of repair. And if we have a failure of the repair itself, we should replace also, which means that whatever the therapy you are choosing, you should be able to reduce mitral regurg as well as surgery. And you should take advantage of improving durability of bioprosthetic leaflets treatments. And we should also keep in mind that full valve sparing is as good as repair if it comes to choose transcatheter mitral valve replacement in opposition to repair. So the clinical factors I would like to develop with you are the following. What we have learned from surgery, although there are some differences, technical differences, it comes to compare mitral valve replacement to repair for ischemic mitral regurg. We know that on follow-up, mitral regurg recurrent much more often in the repair group versus the replacement group. And although there is no significant differences in left ventricle reverse remodeling or in death. If you look at the studies from the transcatheter mitral valve repair, we learned that from MITRA-FR and COAPT, these studies are completely different, but also they showed completely different results. So there is a missing part, and we should understand really what drives the success of the failure of this or that therapy. If we go to the registries themselves, we know that, for example, for this Everest 2 realism study, it shows that despite the possibility to achieve almost 98% of success, but what does success means? It means reduction of the mitral regurg, but not the elimination of the mitral regurg, as you can see it here. You still have in 40 to 65% of the patients, some of them who are above mitral 1 regurg. And if you look, the mitral clip is successful whenever you treat, for example, a P2 prolapse, where it shows the best mitral regurg reduction. That means this solution is not able to provide a perfect result in all patients. If you look at the mitral clip TVT registry, it shows clearly that when it comes to analyze the impact of mitral regurg of 0 or 1 in comparison, or 3 and 4 in comparison of grade 2, it shows clearly that it unfavors mitral clip treatment itself. So there is the unmet need that we have to address. This slide shows also clearly that if you compare the death and the death because of heart failure in the post-op period, whatever you are treating this degenerative mitral disease or functional mitral disease, there is a huge number of patients that cannot get the benefit we would like to have from this therapy. It ranges between 24 to 49% of patients who will not get the clinical benefits we would like it to have. So if we try to go and understand a bit more further, why is this happening? It leads us to discuss the anatomical factors. So I think we all agree that the etiology also the pathology and the anatomy of these patients having mitral regurg are so different that could explain also why there's a wide range of transcatheter mitral repair solutions that are offered. It varies from edge to edge, with, of course, the gold standard today, to annuloplasty, to caudal repair, and so on and so on. And this is why surgeons use many different techniques to individualize treatment as many as anatomies in the nature. And this is also why, if you look at this, surgeons have been always able to combine different techniques in one procedure in order to achieve an optimal result, which percutaneous repair cannot or is unlikely to achieve, and to eliminate and only be able to reduce mitral regurg with surgery. So if we go back to the discussion related to COAPT and mitral FR, there are some specific questions in secondary MR which are not only addressed by the gap between the anterior and the posterior leaflet, which are not only addressed by the volume of the left ventricle and so on. I think there are some specific questions that should be addressed in the future, which are the tenting area, the coaptation distance, that surgeons are able sometimes to address. And despite this fact, the studies showed no major impact of repair in comparison to replacement. So I think this is one anatomical factor that has not been addressed that should be addressed. I took the liberty to add the last column in this slide, extracted from the EXPAND steering committee presented a couple of months ago by Stefan van Baardeleben. Compare NTR, XTR, clip, and how to make the selection of the appropriate patient for these two clips. And I have allowed myself, based on what we know so far, to add a column which could favor TMVI. So if you have whatever the length of the leaflet, whatever the anatomy of ATP2, whatever, if you have a flail or not, redundant leaflet, restricted leaflet, calcifications, a smaller mitral valve area, or a problem that comes at the level of the commissures, these patients could get a TMVR with the replacement, I mean, of course, if they pass the other eligibility criteria that we can discuss later on. But the clip is not always optimal on all of them. And sometimes you have to combine not only two kinds of clips, but clips and some other procedures. I also built this based on what is acceptable in the great majority of centers, and not only expert, because we're talking about the therapy that is global. So we cannot imagine a solution that cannot be global and only dedicated to big volume centers and only skilled doctors. So we know that there are some specific patients in whom the clip or the edge-to-edge repair can achieve perfect results. But we know also that many of these patients are not sent to transcatheter mitral valve replacement today because the solutions that are offered are mainly transapical. And this is something that's going to change in the future. For example, we consider that not suitable for transcatheter mitral valve replacement patients are those who have COPD, respiratory dysfunction, hostile chest, friable ventricle tissue, aneurysm location in their history, some additional valve disease. I think in the future, going to the transeptal solutions, the TMVI will be able to offer a perfect solution for these patients, even those, and especially those in whom we know that there is a low tolerance for residual MR. And we know that residual MR, if we have a patient with a long expectancy of life, could be a game changer on which we have to put a lot of attention. Heart team, if the heart team discussion predicts residual MR equal or superior to 2, I think TMVR is and should be much better than repair itself. And we know that some anatomical echocardiographer factors such like annular dilatation, restricted posterior leaflet, short posterior leaflet, eccentric jets are one of the game changers that could make transcatheter mitral valve replacement a better solution in comparison to transcatheter mitral valve repair. So putting together all these factors and discussion within the heart team confines, we are able to say that we should be able to achieve the same rules as with mitral valve surgery, and always favor repair when it's possible. But there are many scenarios where repair is not possible and replacement should be considered, I would say, privilege. And this is especially in case when transcatheter mitral valve replacement is going to be able to be achieved using the transfemoral approach. And in that case, I think transcatheter mitral valve replacement will be a winner, or a clear winner.
So Thomas, this was a great overview. So as you said, quite a few of these patients who's put forward for transcatheter mitral intervention will not have an optimal outcome after repair. So what patient do you think would be better served with a transcatheter mitral valve replacement?
So Lars, this is an excellent question. So let me answer it partially, please. So if we put away the safety of edge-to-edge intervention and focus only on the optimal result we want to achieve at the level of the mitral regurg with a patient who has a good expectancy of life, if you look at the landscape of the current practice today, we know that more or around 50% of the patients are having surgical replacement and not repair. And if you look at the data together that are emerging from the real world with the MitraClip edge-to-edge repair, we know that at least 25 to 40%, it depends on the disease you are treating, are not a good candidate for edge-to-edge repair. I think putting this together, patients who have a mitral regurg in the future would be offered if we move transfemorally the transcatheter mitral valve replacement over the repair, in my point of view.
So maybe we should move on to try to talk a little bit about transcatheter mitral valve replacement. So I'm going to talk about the Medtronic's Intrepid system for mitral valve replacement and talk about the initial experience from the pilot and from the Apollo roll-in data. So just let's start looking at the valve itself. So it's actually consisting of a dual stent. You have an inner stent at the same size with a 3-leaflet valve and an outer stent of different sizes, so you can tailor that to the patient's anatomy. So the outer stent is going to anchor on the mitral leaflet, and the inner stent, of course, is going to be the valve function. It's a transapical system for the time being, and the latest iteration actually allow you to recapture the valve onto its fully deployed. So it's, of course, a good safety issue that you can have a second chance to reposition the valve if you're not happy about it. So look at the pilot study. 50 patients was enrolled back in 2005 to 2017, and these patients need to have severe mitral regurgitation. And if you look at the data characteristics, you can see it's a typical mitral candidate, younger than what you see for TAVI, early 70s. Most of the patient was male, quite a lot of comorbidity. And also in this study, very interesting, far the majority of the patient had secondary mitral regurgitation. We know these patients are not offered surgery as a routine, only if it has a concomitant procedure to CABG. If you look at the outcome here, the 30 days outcome, this was the very first experience. 7 patients actually died, so giving a quite high mortality rate of 14%. Stroke rate was very low, and otherwise there was some complication, but not too much. And if you look at the efficacy of this, you see most of the patients came in with severe mitral regurgitation, and all the patients, both at 30 days and the latest follow-up, had either none, it was 3 out of 4 patients, or only a mild mitral regurgitation. So very efficient treatment. So the study design for the Apollo trial is that it's going to randomize patients with severe symptomatic mitral regurgitation, either primary or secondary. The heart team is going to discuss whether the patient is suitable or not suitable for cardiac surgery. If the patients are suitable for cardiac surgery, they're going to be randomized 1-to-1 between transcatheter mitral valve replacement using the Intrepid system or cardiac surgery. For the patient not suitable for surgery, there'll be a single-arm study looking at these, and also a subgroup of the patient with severe mitral annulus calcification is going to be recorded, the outcome here. And as you see, there will be a roll-in of between 100 and 250 patients before the randomization actually starts. And if you look here at the roll-in data from the Apollo trial, the first 51 patients, again, same profile as you saw in the pilot study, age, early 70s, most of these are male, far the majority have severe symptoms, function class 3 and 4, and again, 2/3 of these patients have secondary mitral regurgitation. And very important, now you see here after the initial learning experience, 30 days mortality is down to 2%. So only one patient died within the first 1 month. And again, we're up against edge-to-edge repair, which we all consider as a very safe procedure. But 2% is actually in the same range for the 30 days mortality with the Intrepid system as for the edge-to-edge repair. So we can now say we have a very efficient, but also for these, a very safe procedure. I'm just going to end up here to say that the current system is a transfemoral system, but we expect in the very near future, it's going to be a transfemoral system where you do it as a transeptal procedure. And of course, if you want to address these patients where most of them have secondary mitral valve regurgitation with impaired LV function, it's important not to have a transapical approach, but a transeptal approach is probably going to be more minimal invasive and also a more gentle procedure to these patients. So Thomas, we have seen quite impressive results here with the roll-in phase from the Apollo study. But again, we have to remember these patients are quite selected. So how do you see transcatheter mitral valve replacement in a kind of all-comer patients with mitral regurgitation?
So, Lars, this is a very, very good question that we should address following what you have presented. I think we are dealing today with the first catheter mitral valve replacement systems, and we know that's going to change in the future. We have two major limitations today. One is clinical, because the patients are referred very late to be treated, and they have a very large anatomies and dilated annulus, and with very difficult prosthesis to manufacture actually. And also so hopefully in the future, by getting earlier interventions, we could control much better this factor. And the other factor that is responsible for high rate of rejection of these patients is the risk of LVOT obstruction. And I think is also with the new iterations that's going to come, with having low profile prosthesis that have less interference with the LVOT, this rate also of rejection will be reduced. So I think, and also the experience that we are accumulating, better selection of the anatomical factors that could lead to failure or success, the place of replacement is going to grow slowly. I mean, we must not forget that we are really in the very beginning of the replacement experience, where the MitraClip started back to 2003. So I think we should be very careful with this, with any statements that goes against the replacement itself. And one of the major important also elements that could favor replacement, in addition to what you have said, the elimination of regurg, is that it doesn't close the door necessarily to a second intervention in the future, and we will be able to put the valve-in-valve, which is not the edge-to-edge systems.
So we saw that in the Apollo study, there is a single-arm registry on Intrepid in patients with severe mitral annulus calcification. And we know these patients are not very well served with cardiac surgery, and also transcatheter mitral valve repair is not the optimal solution for these patients. So how do you see that transcatheter mitral valve replacement is going to fit into the treatment of these patients, Thomas?
So the Intrepid system is interesting in that it has this outer disc you have alluded to, and the internal disc. The outer disc with its ability to confirm to the surrounding anatomy could behave and espouse, I would say, the MAC area, which actually underestimated in the patients we are treating. We know that in elderly patients, in addition to mitral regurg, there is a big number of patients with a different percentage of calcifications at the level of the annulus, but also at the level of the leaflets. And with this regard, I think transcatheter mitral valve replacement will be a better option and a better solution if we want to achieve a mid and long-term efficacy of eliminating the mitral regurg.
So we have now discussed the role of transcatheter mitral intervention in patients with primary and secondary mitral regurgitation. And we know from the last decade that transcatheter repair, particularly edge-to-edge, is a very safe procedure, but it's struggled that it's not going to give an optimal outcome in quite a subset of the patient who is left with a quite significant degree of mitral regurgitation. And that's why we're now looking where is the place for, or the space for transcatheter mitral valve replacement. And Intrepid, as you have seen here in the roll-in phase, have shown that it's not only a very efficient treatment, leaving almost no mitral regurgitation behind, it's also now becoming a very safe procedure with the same mortality rate as for the edge-to-edge repair. And again, as we discussed, it does not close the door. So if it's going to fail, there's still an opportunity to do a re-intervention, maybe a transcatheter valve in these patients. So with this, I want to thank you for attending this session here. I want to thank Thomas for the discussion and for Medtronic to sponsor it. Goodbye.